Professor Peter Collignon, the latest news from New South Wales may be alarming a few people, but it's pretty much consistent with what you predicted on this very program about 10 days ago, namely there might be a spike in numbers before it plateaued, but not as bad as the Crossroads cluster, so-called, earlier in the year. Do you still adhere to that position?
Yeah, there's a few more cases today than I was expecting, but it was still within two family groups. So if people associate together, and particularly if some of that was inside, then it's not a surprise. But basically, I'm still less worried about this outbreak than the Crossroads one, for two reasons. There were a lot more cases in the Crossroads one, but more particularly it was during winter, so people are indoors more, and that really increases the risk of transmission to others. So I guess we'll have to see what happens over the next week or so. There's not obvious links to particularly this Croyden cluster, which is a concern, but you might remember even the two healthcare workers who were infected, the transport workers. It took a while with genomic testing to check to see that that was in fact part of the Mona Vale Avalon outbreak as well. So I think we'll be wiser tomorrow or the day after when some more genomic testing is available, or tell us, is this Croyden one very much related, similar to the ones that have been in Avalon, etc.? Then we've got to work out how it got there. But the main thing is, with a lot of limitations that have been put on people, particularly over this New Year period, and also because it is in summer and people can be outside more, and perversely because it's maybe a bit cooler in Sydney, so maybe people aren't in air conditioning inside, which is another risk. I would presume that this will all teeter out and go to low cases sort of in early January at least. We'll start seeing 2, 3 cases, then none, maybe 1 or 2, and it'll have this long, slow tail, but it should disappear.
And in terms of its geographical distribution, is there anything about this that's alarming you so far? I know that there was a bit of a fuss about CBD cases being identified, but so far, again, reiterating, you're comfortable that the contact tracing system and the New South Wales measures are suppressing this about as well as one would expect?
Well, I think they are. I mean, if you look at it, 95% of the cases have been linked. Now, okay, there's some cases that we haven't linked and there's new clusters we've got to work out. But so far it's been predictable. It's been, even in the CBD, it was mainly about people being close together indoors in a pub, is my understanding. The Wollongong 2 cases are related probably to being in the CBD at the same time. And most of the others are all to do with going to the Northern Beaches area. In retrospect, It may have started a bit earlier than we originally thought. Some of those Belrose cases suggested maybe, quite early in December there was some transmission and it all came from there. So, we're just going to have to wait. But so far, this isn't anything that's out of control. There's a lot of limits on gathering. Outside is more important than indoors, and all those things, along with wearing masks when you're in situation indoors where you can't avoid other people, all of that makes a big difference. But we've got to remember, most of the transmission, not only in this case, but ever since this started, occurs in people's homes. It's where you're close to other people, particularly if they've got symptoms, because that's much more likely to transmit it. So very much, if you're sick at all, even with what you think is a common cold or a mild anything, at the moment in Sydney or anywhere really, go and get tested. And as much as possible, even if you don't think it's COVID, but you've got any symptoms, keep away from your other family members and friends as much as possible. If there's another bedroom you can sleep in with another toilet, do that until you're better. Because even if something else, you won't know until you've had the test, and it's better being proactive if that's at all feasible. It's not feasible in everybody's houses, but a lot of houses it is.
Okay. Look, a couple of things I'd like to clarify for our audience. Genomic testing, can you just walk us through that in lay people language so we know exactly what you're talking about?
When we talk about genomic testing, it's looking at the genetic makeup of viruses, bacteria. We use that for lots of things. And essentially, it's the same as fingerprinting. You actually look at 5 different localities of viruses, and by doing the genomic testing, you say, hey, these are very similar, or this one's quite different. Like we know ones circulating in the UK at the moment are quite different to the ones in the US and in India, etc. They all change with time. So nothing's perfect, and not only that, 2 people can come back from the US and have the same virus, yet they didn't get it from each other. But it tells us that these are likely related, and therefore for contact tracing, it's much more important to know that than, for instance, with those transport workers in healthcare. Originally, it looked like that was completely different genomics, but I noticed today they've said there was a mismatch in the one of the laboratories doing it, and when they retested, in fact, they were the same. So perversely, that's reassuring. It means there's only one virus that's got out there, and if we can, if you like, track it down, it makes it much easier to get on top of it rather than there were 3 or 4 or 5 different strains that somehow were circulating.
Got you. Now, that brings me to the other point. We keep hearing about mutations. And as I understand it, correct me if I'm wrong, I'm not as skilled in this area as you are, obviously, but the mutation relates to its higher level of transmissibility. It's more infectious, but it is not more lethal. Is that a fair assessment? And linked to that, are you optimistic we're going to get a vaccine before we go back into the cold weather and the longer winter evenings and essentially get housebound again?
Well, a lot of the reports in the media are about this UK strain, and it does appear that more people in the UK in November, December were getting what is a different strain. Now, when I talked about the genomics, all strains vary with time. So what is in the UK is different to what was there 3 months before, because the strains do change. Now, it may be that the strain there is more infectious. Maybe it passes on easier to other people. But that's not beyond doubt. I mean, it may also be because there were a lot more people around in November, December doing Christmas shopping before they had their other lockdown, and that helped spread it. Because the same increase in spreading isn't quite as obvious in the Netherlands and Germany, where this strain has been found also. Now, at the moment, it looks like it does transmit a bit more often, but there's no evidence that it causes more deaths or even more people into hospital proportionately. So that's the good news. The other good news is that it still has, to some degree, the same spike protein which coats the virus. Now, the reason that that's important, or it's not very different, is because that's what all the different vaccines that are out there are mainly directed against. When you get injected with the vaccines, you make antibodies that help kill the virus, inactivate it, but also your white cells are turned on and they recognise that. So far, There's no suggestion that the vaccines won't work against these new strains. And you've got to remember, the whole point of genomics and doing testing is because strains do vary slightly with time, be it golden staph, be it the pneumonia germ, be it this virus. So that helps us track them down. But it doesn't mean the vaccines won't work or it's so different that they don't work. So my view at the moment, vaccines look optimistic. I don't think we have all the data, but they look like they work. They look like they're reasonably safe. And when they get rolled out and we see what happens particularly in Europe and America, we'll actually have added data that it's safe. And I would think most of the at-risk people in Australia are likely to be vaccinated before winter, which is really important. Those over the age of 70, 75, frontline workers, be it wherever they are. And most of Australia, or at least the adults, will be vaccinated probably by September, October next year.
Which is a great piece of news. Professor, do you have a preference between the Oxford AstraZeneca and the Pfizer, or are they both of equal utility? Do you think one is more likely to be successful in Australia? Do you have a view on that?
Well, we're more likely to have more of the Oxford one here because we're going to manufacture it in Melbourne. There's pluses and minuses for all of them. The Pfizer and the Moderna ones are what we call messenger RNA vaccines. They're completely new, never have been used in major ways before. They've got a real problem, though, with a cold chain or an ultra-cold chain. The Pfizer one, for instance, has to be at -70. And that's already proved to be a bit of a problem in Germany, where maybe 10%, at least in my understanding, in Bavaria, the vaccine had to be sent back because the cold chain was interfered with. The big advantage of the Oxford vaccine is it is probably going to be much cheaper, but more importantly, can be held at normal refrigeration temperatures like nearly every other vaccine. So it'll be much easier to maintain the cold chain. It'll mean it'll be able to be given in doctor's surgery more widely than probably the one that has to be stored at -70, which means there'll be one centre with all the right facilities and it has to be given there. So there's pluses and minuses for all of them. As far as the world is concerned, which is important for us too, we're going to have this rolled out globally before the risk gets markedly down. And any vaccine that needs to be stored at room temperature has a big advantage for the cold chain distribution for all the other vaccines we can successfully roll out, rather than having to have -20, but particularly -70 as a major part of the cold chain.
Well, Professor, thank you for shedding your light of expertise on this matter again. Sorry to keep troubling you with it. I'm sure both the Sky audience and your family would be delighted if you didn't have to talk about COVID every other day, but it does make a difference, and thank you for interrupting your busy schedule to share that insight with us. All the best for 2021.
Thank you, and same to you.